Okay, we're going to learn how to identify some rhythm strips. So the first thing we have to be able to discuss is what it is we're looking at. So when you have a rhythm strip, you've got 6 seconds worth of a patient's rhythm. I've tried to draw this out as best I can with the electronic resources that I'm familiar with, so this is going to be very crude. This orange line you see across the page is what we consider our isoelectric line. So all of the electricity is going to try to come back to this line. So we have on the long axis where that line is, that's time. As it goes across the page, time is passing by. So time, and we're going to call that in seconds. And then this is going to be the energy, or we're going to put that in millivolts. And so we'll be able to get a reading of how much electricity is going through that patient's heart in that moment based on what we can tell by using leads outside of the body. So as time goes on, one of these small boxes, so if we're starting here and we're counting time from this small box to this end of this little small box here, this is going to be 0.04 seconds. That's a very, very small amount of time. As we go on, if we're going to double that, it would be 0.08, 0.12, 0.16. It's going to be 0.2. So we would consider this what we call a big box. So on your strips that you're going to see small boxes, and you're going to see much darker big boxes. And so you might see something that looks like this, and like this, and then inside of it you'll see some other small boxes. So if you're counting big boxes, each big box on the time axis is going to be 0.2 seconds. So for us to get to 1 full second, it's going to be here, and then you times that out 6 more times, and you're going to get a full 6-second strip. For the purposes of this, we're probably just going to go through maybe 1 second worth of strips. Okay, so what are we looking at? As electricity flows through the patient's heart, we're going to be able to capture what that electricity looks like. And so we're going to see something that looks like a P wave. We're going to have a pause. We're going to see a QRS occur. And then we're going to see a pause. And then we're going to see a T wave occur. My P wave seems a little large compared to my T wave. That's not accurate, but you get the point. So when our heart is sending electricity from its SA node, it's sending the electricity, or the impulse, at 60 to 100 beats per second per minute. So it sends its signal, sends it down to the AV node, and we capture that on our strip as a P wave. So I'm going to draw this again, but I'm going to draw it in this blue color here. We're going to have nothing occurring until that SA node sends its signal. We're going to have a P wave occur, and then we're going to have a pause. You remember from lecture, the AV node slows that signal down so that atria can contract. And so when we have that pause in the electricity firing, the atria is contracting. We've got a pause that's established here on our timeline, and so the electricity is basically just stuck in this AV node for the time being. Once that electricity gets down into the bundle of His and starts going down into the bundle branches and into the Purkinje fibers down to the ventricles, we're then going to see what the electricity looks like as it's coming down towards. And so remember, lead 2 is looking this direction. So we have everything, all the electricity at this point has been turned towards us. It's flowing towards us. So when we have the electricity being sent towards us in that lead, we're going to see upward deflection. That's called our R wave. So we have an R wave being formed by the electricity flowing down into this bundle of His, bundle of His, yes, but then down into these bundle branches. As the electricity then turns in that corner, and it's going to go the opposite direction to go up each ventricle to make the ventricles then contract, we're going to see the downward, because this electricity is now moving away from us, we're going to see the downward spike. After that, we're going to see it all kind of reset, And as the um, ventricles repolarize themselves, we're going to see this T wave occur. And that's just the electricity resetting itself. Okay, so electricity will basically be coming back towards us because it's a positive. It's going up on our strip. Okay, so what are we actually seeing? We have established that we have a SA node firing, causing the P wave. We have this pause here while the electricity is stuck in the AV node. The first positive deflection we see is the establishment of our R wave, and that is the first positive electricity that comes out of that heart. And then as we go negative, we're going to start to see the ventricles being primed for contraction. And then as everything resets, we see the T wave here. So let me mark this. I erased it, Angela. Okay, let me redo our P wave. P wave. I can't get it exact. Okay, so we have our P wave. We have an R wave. This would be our S wave, and then we have our T wave. Now, it's supposed to be a QRS. Now, normally, physiologically, we do not see Q waves, but if we were to see Q waves, they would be here, and it would be the first negative deflection you see. These would be a pretty bad sign. Sometimes it's not that bad. Sometimes young people have Q waves and they're perfectly healthy and fine and it's whatever. But if you see a very, very large Q wave, or it goes down first and then it goes up, that's indicating that the patient's had a previous MI. Or they've got some scar tissue that the electricity has to go around to get the electricity to flow. So instead of coming straight down, the electricity has to go around. And when that happens, you get a Q wave. So Q waves, really pronounced Q waves, are an indicator of an MI, an old one anyway. Okay, so now let's interpret our rhythms. So what we should see with every single beat should have what we have already established. We should have, let me make my isoelectric line. Let's see, let's go right about here. So we've got our isoelectric line. Everything's going to come back to that. Let me change colors again. And we're going to go with, I don't know, we'll go with green. Okay, so for every beat of the heart, we should see a P wave, we should see a QRS, and we should see a T wave. Okay, that's every single beat should be like that. So if every single beat that we have looks like that, and then it goes into another P wave, QRS, oh, that's kind of ugly, QRS, and a T wave. Let's go T wave, and then a P wave, a QRS, and oops, I forgot my T wave. If every single beat has a P, a QRS, and a T wave, we were going to call this sinus. So if everything has the requirements for sinus is P, it has a QRS, and it has a T. Okay, that's a requirement for sinus. Now everything should be how it should look in the respective lead. In lead 1 and lead 2 that we're looking in right now, we're looking in lead 2. Everything should be upright. Our P wave is upright, our T wave is upright, and our QRS is actually biphasic, so it goes up and down. That's how lead 2 should look. And we would call that sinus. Now, if we take the full 6 seconds, I'm not drawing the full 6 seconds here, but if we draw the entire full 6 seconds and we see that the amount of QRSs that we have is between 60 to 100, or on our strip we're going to see between 6 and 10. If you see 6 to 10 QRSs in that 6-second strip, we're going to call that normal sinus. Okay, normal sinus, we call it normal sinus rhythm. So that is anywhere from 60 to 100. It's the normal beat of the heart. So 60 to 100, normal sinus rhythm. NSR is another thing that we call it. If we count them out, and the rate of the beats is anywhere below 6 in a 6-second strip, so you have like maybe 5.5 beats that you've counted. We're talking about counting QRSs. You are going to have what we call a bradycardia. Still sinus because you have a P, QRS, and a T for each beat. But if it's below 60, so it's under 60, it's going to be Brady. Sinus Brady. Sinus Brady, sinus bradycardia. If you can imagine anything above 100, so let's go with above 100 is going to be sinus tachycardia. So sinus tachycardia is my abbreviation for that. This would be SB. So the only thing that's different between any of these is the fact that the beats are faster. Or the beats are slower. So you got to count the QRSs for that full 6 seconds. There's other ways to calculate it. You can take how many big boxes between the R's and divide that by 300. You can count the small boxes between and divide by 1500. The easiest way, quickly to glance at it when you're in the rig, the easiest way to identify that is just by counting out the 6-second strips. Your monitor is probably going to give you the heart rate. Okay. So that's how we identify that. Now, moving on to some other things. So the P to the Q interval, P, Q, let's see, let me draw this. Okay, so like I said, we don't normally see the Q, so we're not going to even call it that. We're going to start here and here. So we're going to we're going to count how much time from the beginning of our P wave to the beginning of our R wave, and we call that the PR interval. And so let's go with this one here. So we're going to count from here, and we're going to go to here, and we're going to count how many boxes are between there. So we're going to go 1 box, 2 box, 3 box, 4 box. 4 small boxes is going to be 0.12. I just know that because I've done this so much. Actually, I lied. It's going to be 0.16. So take 0.4 times 4, and that's going to be 0.16. Okay, so 0.16. The normal between the beginning of the P wave, and the beginning of the QRS should be less than 0.2, and it should be greater than. Let's see, I wrote that the wrong way. It should be less than, and it should be greater than, I want to say it's 0.10. So it should not be super short, and it shouldn't be super long. If it's super long, there's a block in there somewhere, so the amount of time it takes for the electricity to get from the AV node to the SA node, I'm sorry, I said that wrong, SA node to the AV node, there's something in this atria that's blocking it, so the electricity has to take longer to get there. If the signal is too short, that means that it's not actually coming from this SA node, it's actually coming from somewhere not all that way up, so it's a shorter period of time that it has to travel from here to here. So we have names for that. So if our say for example, we talked about normal sinus rhythm, what it looks like. We have a P, QRS, and a T for every single beat. Say for example, we have a blockage. Let me draw it in black because black seems bad. If I have a blockage here in my heart, I'm not going to be getting a signal from my SA node. So what would my rhythm strip look like at that point? So the rhythm strip should have a couple of things that can occur. One thing that can occur is you don't get any, I don't want to do that. You don't get any P waves. So what if you see a rhythm strip that just goes straight to QRS, 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 QRS. Left off my T waves kind of on purpose, but okay, so we'll add the T waves in there. If you don't see any, if it's just flat in this section before the QRS, that means the signal is not coming from the SA node. And if it's not coming from the SA node, it's coming from somewhere around the AV node. And what we call that is we call that the junction. That's the junction where the atria and the ventricle meet. So that's where that electrical pulse is being stimulated from. Now what you would normally see is the backup rate taking over, so the rate should be between 40 and 60. So if you have a rate between 40 and 60 with no P waves, more than likely you have a junctional rhythm. So we're going to call that junctional. Okay, so that's junctional. You still have an upright QRS. The QRS still pretty much looks the same, but you're missing you're missing your P waves. That's what a junctional rhythm would be. Now, if the junctional rhythm is faster than 40 to 60, say that the rate is actually 60 to 100, or let's go with 60 to 100. If the rate is 60 to 100, we're going to call that 60 to 100, but it's junctional with no P waves. That's going to be what we call accelerated junctional rhythm. If that rhythm is greater than 100 beats per minute, we call that junctional tachycardia. Okay, so now what happens if we have, let's go back to black because it's bad, if we have a blockage somewhere down in here? Well, we're not getting a signal from anywhere above that. The signal is actually coming from the ventricles. So the signal is coming from the ventricles. Let's draw this in, maybe we'll do red. Okay, so if our signal is coming from somewhere lower, we're going to see really, really bizarre QRS waves. Our QRS is not going to be skinny, it's going to be really fat. And so it may look something like this. And it goes like this, and it goes like this. Okay. Now, because of the intrinsic rate, it should be anywhere from 20 to 40. So if it's 20 to 40, and all you see is these really super wide and bizarre beats, that means that there's no signal from the SA node, there's no signal from the AV node. This is straight ventricular, and we would call this a ventricular rhythm. And we would actually call this what we call an idioventricular rate, idioventricular rhythm, and it should be between 20 and 40. Now, if it's faster than 20 to 40, then we would call it accelerated, just like the other one. And then if it's even faster, and sometimes these will look really, really weird. We can see one that looks like this, and some of you may already recognize that the McDonald's signal, the M's. If you see that, that's what we call V ventricular tach. V-tach looks really bizarre because it's these here, but they're just really smushed together. So that's what V-tach looks like, and that's any ventricular rate over 100. So the tachycardia has to be greater than 100 to be tachycardia. And sometimes these rhythms are 200, more than likely closer to 200. So if your rate is anywhere lower than 20, that's just basically, we would call that an agonal rhythm, where you just maybe have like a flat line for a really long time, then you get like one super lazy beat. Out of the entire 6-second strip, you might get one of those. And that's like an agonal. That's a dying heart. That's not life sustaining in any way. Neither is V-tach for that matter. Okay. We've covered the major parts that I wanted to cover. Now we got to get into the other parts I wanted to cover. And so we have the establishment of what normal sinus rhythm looks like. We know what sinus brady looks like. We know what sinus tach looks like. We know what a junctional rhythm looks like. There's no P waves. I guess I should add in here. Sometimes what happens in this junctional rhythm is you get a P wave, but it's super, super close to your QRS, and it's less than 0.1 seconds away from there. That means that there is some sort of electrical signal before that AV node, but it's not coming from the SA node, so we'd still call it a junctional rhythm. Another thing that can happen is you actually get electricity that flows backwards from there. So it's initiated from this AV node, but when it goes backwards, it's sending the signal forward and back at the same time. there's that. Like that can happen. So that would still be considered a junctional rhythm. So either you have a P wave that is upright, but really, the PR interval is really short. You have an inverted P wave, or you have no P wave. Sometimes what will happen too is your P wave will come after. It'll come after the QRS, and that's just retrograde. It's moving backwards, but it still would be considered a junctional. So there's a lot of different things that can happen with that, and it can make identifying your rhythm extremely difficult. But I guess one thing that we should point out is if you have a skinny QRS, it's the QRS, I guess I should mention, it should be less than 0.12 seconds. Anything greater than, I'm lying to you. It should be, yeah, no, that's right. It should be smaller than 0.12 seconds. If it's greater than that, we were going to call that a bundle branch. There's a block in there somewhere. It's taking longer, especially if it looks like this. Okay, so we've established that it should be skinny. So if it's not skinny, then the electricity is probably coming from the ventricle. If it's not skinny, it would look something like this. Okay. If it looks somewhat like that, there might be a bundle branch, but if it looks like this is for sure ventricular. Okay, so we've established that. Now, what if we have a sinus rhythm, and the sinus rhythm looks beautiful, but all of a sudden, let's go back to our rhythm that we have. Let's see if I have room down here. We have this beautiful sinus rhythm going on. You know what? Let's just move this whole screen over. Okay, let me draw a beautiful sinus rhythm for you. Okay, so let me actually use that some more. Let's do, oops, doesn't want to do that. Okay, let me do a black dot here, a black dot here, a black dot here. I'm just going to try to make this as even as I possibly can. My black dots aren't showing up. Okay, well, you're going to get the hint, I hope. Okay, so I have a QRS here, QRS here, QRS here, QRS here, for the most part. Alright, I've got a P wave, P wave, P wave, P wave, yeah. And then I have a T wave. Let's just connect that together. T wave, P wave, Q, P, T, okay, and a T. Okay, that looks really sloppy. Okay, it is what it is. So if my markings all line up, you know what? I really hate this. We're going to start this over. This is really, really awful. Okay, I'm just going to free draw it, and I hope you get the hint. I hope you get the point. Okay, so I have my P wave. My SA node is fired. It's stuck in the AB node. I'm going to get my QRS, my repolarization of my ventricle. I'm going to get another P wave, I'm going to get my QRS, and I'm going to get my T wave. And then I'm going to get, let's say I'm chugging right along, and I got my P wave, my QRS, my T wave, and then boom, a P wave, and let's do a T wave there. And then we're going to go back. Let's see, how far is that? Let's go here. Okay, so as you can see from here, the distance from here to here is established. And what I tried to do is draw the same amount of distance from there to here. Sometimes what will happen is you'll get, and you're trying to get from this next beat and take the same amount of distance from here to here, and it should be here. Sometimes you'll get this beat that pops in early. Yeah, I hope you can see that. So where is it? This is my normal beat, my normal beat, my normal beat, my normal beat, okay? But I get this one beat right here that comes earlier than it should. It's got to try to figure out what kind of beat it is, first of all. But it came earlier than the beat should have came. And so we call that premature. Something comes early, like a premature baby, premature. So it's premature something, right? So we've already established what our atrial should look like, what our ventricular should look like, and what our junctional should look like. So if we have a P wave, it should be, if it has a P wave, it may be a premature atrial contraction. If it doesn't have a P wave, So no P wave, or in this case, it shows a really short PR interval, so decreased PR interval, or maybe it could be an inverted P wave, so P wave inversion, or what else could it be, or a delayed P wave, like a late P wave. We'll just call it a late P. If we have that, and this is junctional, so it would be a premature junctional contraction, a PJC. If it was super wide, didn't have a P wave, and it was super wide, we would call that a premature ventricular contraction, a PVC. So wide QRS that just pops in out of nowhere. So say it was happening here, it just pops in right there, and it has no P wave attached to it. It's pretty wide. It's not like slender like these are. It's really wide. That's ventricular. So we can have a PAC, a PJC, or a PVC. Okay, so it's premature. It comes earlier, and then what will happen is it'll just go back to its regular beat. So that's what normally happens. They'll just pop in every now and again. So if they pop in like that, they're premature. They're not coming when they're supposed to. If it's coming from the atrium, then it's an atrial contraction. If it's coming from the ventricle, it's a ventricle contraction. And if it's coming from somewhere other than those two, it's junctional because it has no P wave, or it's got a decreased PR interval, or it's got a P wave inversion, or it's got a late P, then it's junctional. Now those are a little bit more rare. PVCs are pretty common. I have them all the time. I can feel the skipped beat. It feels like a skipped beat. PACs are pretty common too. Okay, so those can be electrolyte issues that we have to figure out. Okay, so we've talked about our premature beats. Sometimes you get the atria that let's draw our picture of our AV node, our SA node here. Our SA node is supposed to be the shot caller that tells everything else when to go. Sometimes you have multiple wannabe shot callers that are trying to send all these signals to the AV node saying go, 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 go. And what does that look like? Well, the P waves look like they look like that. Eventually the AV node's like, all right, I'll go. And it'll have something like that. And then it's going to send all of its signals yet again. I'm in charge, I'm in charge, I'm in charge. And it'll look like this. And then eventually the QRS is going to be like, okay, fine. And then it'll happen again. Every single beat this happens. I want to be the boss, I want to be the boss, I want to be the boss. Okay, go. And as you can see, this rhythm is really irregular. And you don't see really discernible P waves. You don't have one clean P wave like this one. You've got a whole bunch of little P waves in there that are not even measurable because it's just impossible to count them all. And you have these skinny QRSs. This is what we would call, wait for it, atrial. Wait for it. It's coming from the atria, right? The atria is the one that's causing this problem. Atrial fibrillation. And we know that as AFib. That's what AFib looks like. We have another variation of this where we've got maybe a couple of wannabe shot callers. And so what it'll look like is we'll have maybe one here. And the electricity kind of like goes around in a circuit. Like it's like do, 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 and then it goes through. And so what that looks like is it goes it's supposed to look, that's supposed to be skinny, not wide. It's supposed to look like a sawtooth. I'm a terrible drawer. It's supposed to look like a sawtooth, and a sawtooth rhythm that's pretty regular, like the regularity of the QRSs is pretty even. Like you got 3 like sawtooth teeth between each one, and each beat's coming on time. This is what we would call atrial flutter. Okay, atrial flutter. Now, what happens if we have maybe nothing coming from up here at all? So instead, let's draw this down here. Instead, I have nothing coming from the top, and I've just got like this heart that's like trying to send all these signals out at once, trying to get anything stimulated to go. What you'll see is this. There's no QRSs because it's completely irregular. It's not working well. This is what we would call ventricular. Ventricular what? Fib. V-fib. You're doing compressions on this patient. You're going to be doing compressions. Okay. If you see this, that's the best way I can possibly draw that. That's V-tach. V-tach. We got some other variations in here too. We have something called SVT, and the S of SVT, so it kind of throws you off like it's ventricular tachycardia, and it's not. The S kind of, I feel like they shouldn't have called it this because it makes you think that it's something else, but this S stands for supraventricular. What does supra mean? What is super? Supra means above. What is above the ventricle? If we draw our heart out again, let's draw our heart out again. What is above the ventricle? The ventricles are here. What's above it? Here, or atria. This is actually more of a atrial tachycardia, but we do call it SVT, but it's supraventricular. It's coming from the atria. So it's really hard to see it when it's going so fast, but what you see is a QRS, and then you'll see like your T wave with a P wave on it, and it's just really tall, and it's tall, and it's tall, and it's tall, and it's I can't draw it fast enough. I can't draw it like it should be. But if you practice these, you look at these often enough, you'll be able to see each beat comes on cue. It's really rhythmic. Mine's not that rhythmic, but each beat comes on cue like it's supposed to. So it's hard to tell what it is. It could be an atrial flutter, because atrial flutter, like we had talked about, is regular. Atrial flutter is a regular rhythm, but so is SVT, and we treat these differently. Atrial flutter gets defibrillated, and supraventricular tachycardia gets adenosine first. I mean, you can always have them Valsalva, and that never works, and you can give them desdenosine, and then you can defibrillate them. They both end up pretty much in defibrillation, but or cardioversion, I guess it would be cardioversion. But either way, it's really hard to tell what you're looking at, but the P waves and the T waves are kind of on top of each other. So what am I missing? I think I've covered most of the things you're going to see. The only thing I didn't cover is the blocks, and this is already 30 minutes long. Let's get into the blocks real quick. So we already just established the normal amount of time it should take for the P wave to go through the AV node, and that is less than 0.2 seconds. If it takes a long time for that signal to get through, where it's like, okay, then go, and then you got your T wave, and then you've got your P wave, and then it's like a long pause, and then your your QRS. From here to here is our PR interval. And that's really long. It's more than the little 5 blocks it should be. It's, I don't know how many. 1, 2, 3, 4, 5, 6, 7, 8, 9 blocks. So way too long. It should be less than 5 blocks long. So that would be what we would consider still normal sinus rhythm, because we have a P wave and a QRS and a T wave for each and every single beat. So we would call this NSR, but we would label it with a first degree block. So first degree block is basically our PR interval is greater than 0.2 seconds. It's just taking a long time for the electricity to get from here to here. There's some sort of blockage in here that's causing electricity to have to go around, and it takes longer to get there. Okay? So that's a normal sinus rhythm with the first degree block. Now, we have NSR with a second degree as well, but there's 2 types of second degree. We have second degree type 1, and we have NSR with second degree type 2. And these are really hard to remember. And so what I do is I have to remember longer drop. So longer drop. So what happens is we've got a P wave, Q. I'm gonna leave my T waves off for this demonstration because it's just already too much for me to remember to draw. So we have a isoelectric line, we've got a P wave, and we have a QRS, and it's like, okay, it looks normal. And then we have a P wave, and we have a QRS, and I'm leaving off the T waves, remember. And then I have a P wave, and I have a really long, and then I have a P wave, and then nothing, and another P wave, and a QRS, and a P wave, and a QRS. That's really ugly. Okay, so the point is it's long, longer, even longer. This PR interval is getting longer and longer with each beat. So from here to here, it's like 2.5 boxes. From here to here, it's like 3 boxes. From here to here, it's like 1, 2, 3, 4, 5, 6, 7.5, almost 8 boxes. And then we've got this P wave with no QRS attached to it. Like it's just gone. So that's our longer drop. So this is the dropped beat here. So that's kind of the requirement for this. The PR interval has to get longer and longer and longer, and then you eventually drop a beat. So that's a drop a beat. Anyway, that's what normal sinus rhythm type, the normal sinus rhythm with a second degree type 1 looks like. And then we have normal sinus rhythm with a second degree type 2. And so what this looks like is the P waves, the PR interval is the same. So PR interval is the same. Okay, so P, QRS, P, okay, P, QRS, P wave, QRS, P wave, QRS, P wave, P wave. Okay, so I tried. Okay, so from here to here, the PR interval is, I don't know, 1, 2, 3.5 boxes. This one's like, just pretend it's 3.5 boxes. Here it's 3.5 boxes. Here it's 3.5 boxes. This one, it's maybe going to be 3.5 boxes. So the PR interval is always the same, but you get this P wave with no QRS attached to it, like it's missing. And when you have when it's missing like that, then we're going to call that the second degree type 2, where every now and again you just get a missing drop, missing beat. So that's what that would look like. And then we have a third degree block. So our third degrey block, we call it a complete heart block. Complete. I don't know why I drew my E like that. Complete heart block. Okay, so complete heart block. Basically what's happening here is, the best way for me to draw this would be to just draw a bunch of P waves. So I'm going to draw a P wave, a P wave, a P wave, P wave, P wave. Nah, I messed that up. Okay, let's try this. P wave, P wave. And I try to draw them all evenly spaced. So P waves are from our atria, correct? Our atria is firing like it should. P wave, P wave, P wave, P wave, P wave, P wave. It's going to the beat it should be going to. It's each beat is coming on cue. It's what we could consider marching out. You can take a ruler and measure between the two, between each beat, and it's always going to be the same. So that's the atrial part of it. So we also have a ventricular part going on too, but the ventricular part's going to be wide, and it's going to be acting kind of crazy. No, I don't want to draw that there. Let's just erase that bad boy. Go back to my red. Okay. Instead, we'll draw it here, and we'll draw it here. And it'll come here, somewhere in there. Okay, so what would this actually look like? Let's go like this. It would look like this. This is probably going to look bigger because it's going to be both of them together. And this will look like that. So they'll kind of merge together in some places. I tried to draw this as best I could. So basically what happens is our ventricle, if we measured out our ventricles, this one's beating here, here, and it's pretty rhythmic itself. The P waves have their own interval. So the P waves are going when they're supposed to. The atria is sending its signal like it's supposed to. But then the ventricle is like, I don't hear you at all. I'm just going to go when I want to. So it's going to go at its own rhythm, and it's going to be rhythmic. And as you can see, if this is a 6-second strip, it's going 40 beats per minute. It's probably a little fast for our ventricular rate, but either way, they're not communicating. So what the way that I like to kind of think about this is, if we have a husband and wife, and husband and wife, they're newly married, and everything's going great, and they are in a sinus rhythm. They're working well together. Every time she tells him to take out the trash, oops, that's a little too fast. Okay, so every time she tells, Atria is the wife, by the way. So Atria is the wife. So let me get a pretty wife color. Purple. Is that a wife color? I don't know. Okay, so we've got the P wave. She tells the husband to take out the trash, and within a certain amount of time, he takes the trash out. And then the next time the trash has to get taken out, she says, "Hey, take out the trash." And he's like, "Okay, I'll take out the trash." Take out the trash. Okay, I'll take out the trash. And that's just the way it goes. She says it and he does it, and that's happy wife, happy life. They're happy. They're good. Everything's going well. As they develop a first degree, he's now kind of getting a little sick of taking out the trash, as you could imagine. And so she says, "Take out the trash," and he's like, "Oh gosh, I want to do this first. Okay, now I'm gonna go take out the trash." He still takes it out, but it just takes longer for him to want to actually take the trash out. So the next time that she says, "Take out the trash," he's like, "Oh, I don't want to take out the trash," and he will eventually take out the trash, but it takes a lot longer for him to get out of there and actually take out the trash. When we have a sorry, that was a first degree. Yeah, that was a first degree block. So we go into our second degree type 1. What will happen is she'll say, "Take out the trash." He takes it out pretty quickly, and then she's like, "Take out the trash," and he'll like wait a little bit longer, take out the trash, and then he'll wait even longer. She says, "Take out the trash." He'll wait even longer because maybe they've had like this discussion about it, like, "I don't want to take out the trash," blah 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 blah, and then finally it takes longer. And then finally he's like, "You know what? I'm not gonna take out the trash. Like, you can take it out yourself." And then they have this honeymoon period where I was like, "Okay, I'm sorry, I didn't take out the trash. I'll do it." And then she said, "Take out the trash," and he's like, "Okay, I'll do it." Take out the trash. Okay, we're kind of. I'll take it out. And then eventually they'll wind up right back where he just refuses to take it out, and they'll have that honeymoon period and it'll be all good again. Second degree type 2. It's either he's going to take it out or he's not going to take it out. There's no like quarreling between, like we're kind of fighting in between each time. With second degree type 2, she'll ask and he'll take it out. She'll ask, he'll take it out, and then he's just not going to do it. So it's either he's going to do it or he's not going to do it. And then the next time she asks, he does it. He does it. He doesn't do it. And it's pretty rhythmic still. And it's either he's going to do it or he's not going to do it. And then complete heart block. She says, "Take out the trash, take out the trash, take out the trash, take out the trash." And he's like, "I'm going to take it out whenever I want. I'm going to take it out whenever I want. I'm going to take it out whenever I want."